if you could go back to your first year and like back in like 1935, what? So it feels weird like carrying a backpack and walking on campus.
Did you have your little lunchbox?
All right, guys. So we're back to Classroom to Clinic. So it's a podcast where we're trying to bridge the gap. I am Jake Manley, a student physical therapist. And then we have Brad Langley, who has been a physical therapist for 15 years now. Last episode, we talked about tissue healing. It's been some time since I've seen you, Brad. So how's everything going with you?
Oh man, you know it. It's good with us. You get into the clinic, you're kind of in the grind. So getting them in, getting them out. I'm anxious to hear about the test. I think last time we talked, you had some tests on the horizon, kind of your first big week of legitimate physical therapy school test. So I'm anxious to hear. You're kind of smiling. We're still doing this podcast, so maybe they turned out good.
You may be a little disappointed in me.
Uh-oh.
So we had 5 exams in 1 week. I think we talked about that last time. Made it
Mm-hmm.
through that. It kind of made me like just get lazy for a little bit because I was just kind of tired from all the exams. But I had a neurobiology exam, which was the one I was most worried about. So I procrastinated a little bit. On Sunday, Sunday comes around. The test is on Monday at 8 a.m. We have a practice test. He gave us a practice test. I took the practice test at 10:30 p.m. and I made a 59.
Ooh.
So I just full panic mode because that would make the exam in about 9 hours. But I was about to wind down, go to bed. I thought I was going to make like a 70 on the practice test and then sneak through a 80 the morning of. So I stayed up all night, got to the library at like 5 a.m. and then went to the neuro test. I ended up making an 88, so it paid off. Through the 59, all I thought about was like I'm about to get kicked out. Like it's just done. I'm gonna fail the first neuro exam. There's no coming back. So I felt a lot better once I got through the neuro test. So I've had an exam almost in every class. Straight A's so far. So we're alive and doing
Wow,
okay.
that's crazy, man. That's so stressful. Makes me sweat thinking about it.
My hands are sweating right now, like reliving
Man.
instances like that when you're in school that you can remember.
Not too bad. I think there was one instance where I actually forgot that we were having a test, but we didn't have the practice test. Number one, that's cool that you can do a practice test. Maybe it's cool, maybe it's not. I don't know if that, but there was one instance. I don't even remember what class it was, but I get the class, think it's just gonna be a regular day, and I see everybody else is kind of studying and cramming a little bit. I'm like, well, what's going on? They're like, dude, we got a test today. Luckily, I guess maybe the microdosing study habits that we talked about on episode 1 maybe bailed me out. I ended up doing fine, but thank goodness. But it's super duper stressful. That's great. Maybe next time take the practice test like at the beginning of the weekend.
Yeah. Well, I was thinking like, I studied like one PowerPoint that I didn't feel good on, like really heavily. It was the cranial nerves. I was like,
Oh
oh,
yeah.
I'm good to go. So I felt confident about it. And like as soon as that score popped up, like my heart just sank to my stomach. Terrible.
That's pretty funny. All right. Well, so you survived. So thank goodness you're still in. They didn't kick you out after that. So that's pretty good. So what have you been up to? We're kind of, well, I mean, we're rolling through this thing. We're pretty close. I guess this is about the halfway mark. Is that right? No. So we're a third of the way through.
Yeah, it's getting close to half because we get done right before Thanksgiving. So it's going by pretty
Awesome. Yeah. So you're rolling. What's the next big thing that y'all been talking about?
So most of the like classes have been a lot of textbook stuff just because I think it's the first year and they're trying to lay the framework. But with the more hands-on classes, we've been doing a lot of modalities. So getting into like ice massage, ace wraps. We talked loosely about like E-Stim and ultrasound, but we haven't been able to do that in person yet. I think that's something we'll do down the line for sure. But we just had a practical on ice and ace wraps. And then I assume we have the other modalities coming up soon.
All right. Well, have you ever had physical therapy? Have you ever been a physical therapy patient? I don't know if I even asked that question.
I was once. It was actually with Thad from the Thad.
From work. Yeah, yeah.
Yeah. So I sprained my ankle 2 times. I actually now have another funny story. So I sprained my ankle in practice, like a school practice. that helped me get back and all that fun stuff. And then our coach was like strict because he wanted us to be good. So he was like, if you go play pickup, like at this rec center, like you're done. You're not gonna be on the team. I go, my teammates end up talking me into playing. First play, I sprained my ankle again, the same ankle. So then I didn't do rehab because I didn't. So now my ankle's a little messed up. But I've only had rehab once, and it was a long time ago.
What kind of modalities did y'all use? Did y'all use anything? I mean, obviously, ice is pretty well known. And most people, even your layperson, understands that if I have an acute injury like an ankle sprain, they typically go to the ice. What did Thad use? Did he use ice or E-Stim or Ultrasound? Or, I mean, y'all may not even had that.
Yeah, it was definitely the school we were at was very outdated. So the new training room is a lot nicer from what I heard, but I think all we had access to was ice. So we used ice for sure. Ice the ankle like after practice and stuff, and then just a lot of activation stuff and getting the swelling out, which is stuff we've been talking about a lot is swelling, and then of course going from the learning the healing phases and then how we can use the modalities to help the healing phase.
Right. So what are they, when they say modalities, what's the definition? Do they give you like a working definition? Because that's one of those weird things. Like I'll make a comment, maybe it'll be an athlete that I see and I ask them, hey, what kind of modalities y'all been using? And of course, they don't know what I'm talking about. But what's just so we can kind of frame our conversation around how we're going to use these modalities. What's a good working definition? And if they didn't give you one, maybe just make up one.
Yeah, they definitely probably gave me one. But when it's words that I know, it's like so hard to remember the definition. I don't know why. Because the definition is like the textbook definition is way more complex than like how I remember it in my head. Because it's such a simple term. So they probably did give me one, but I do not remember it. My definition of modalities is anything outside that I eventually as a physical therapist would use that's not myself. So no manual therapy, not exercise or interventions, but external sources that I could use to try to help the rehab process for my patient.
Yeah, I think that's a fair definition. I'm kind of like you. I don't know what the technical big words would be, but yeah, you're absolutely right. They're kind of just, there are these helper things that we can use. And sometimes it has to do with like a thermal modality, which would be like ice and heat, where we're either giving heat to the system or taking heat away from the system. E-Stim is a pain control type thing, obviously electrical stimulation. So we're using electricity. Compression is one that you've talked about a little bit. And so you're absolutely right. I think that's the easiest way to think about it is these are things, tools that we're going to use to really help us meet our goals and actually get some kind of physiological change happening in this patient. Cool. All right. Well, let's do this. Which one you said y'all talked about? Ice and heat, I'm assuming.
Mm-hmm.
And then a little bit of ultrasound, you said, but haven't done it.
Yeah, we went through all the types of modalities like thermal, mechanical, acoustic, and there's one more and I can't think of it off the top of my head. But the practical we just did, it was either the ice pack or ice massage, which ice massage was something I'd never seen before. Of course, everyone's seen the ice pack and heat packs, but I'd never seen an ice massage before. Of course, on the practical, I got the ice massage and my partner got the cold pack. The ice massage was pretty easy. Basically, all I had to do for the ice massage was we're just trying to get the area that we're treating to be numb.
Good afternoon.
There goes Siri. We're trying to get the area we treated to be numb. So I would just go in circles over the treatment area, get the patient to respond to me if they still have feeling just to the touch. And then when the patient identifies that it is numb to me, then the treatment would stop.
All right. That's pretty basic, right? And that's generally, that's kind of what ice is used for. We think of it like you're talking about, I sprained my ankle. We typically think of ice as like an acute thing. And so, well, how about this? Why don't we just kind of go through some examples, if you're cool with that, and we'll just kind of walk through how maybe what they're teaching you in school or what they're teaching you about these modalities, and then maybe how we can use them in the clinic. Does that sound like a plan?
Yeah, that sounds good. I think especially with ice is a hot topic with it maybe impeding the rehab process, maybe not. So I'd like to see on that and what you think of it in the clinic after all those long years.
Right.
Yeah.
Right. So ice is the easy one to get started with because, like I said, everybody knows that. My grandma knows to put ice on something that hurts, and that's probably your first experience. I remember back in the day of playing football, and we would sprain our ankle or something like that, and we get the old garbage can. Our coach would bring a garbage can out, pull the garbage bag out of it. He didn't even clean it, so it's like nasty. Fill it with ice water. Just stick your foot in that thing until you can't feel it anymore. It's like, wow, this is super scientific, coach. Thanks. But so yeah, that's basically what it is. We're using that thing to really control that acute pain. Obviously, if the ice is there, it's going to numb all those little nerve endings, those superficial nerve endings. And so it really, really does help control some of that acute pain. Now, obviously, when the tissue starts warming back up, all that stuff's going to come back. So, do we ice it again? Do we not? It really kind of depends on the person. And that's what nobody likes to say about heat or ice. So I'll just say it. It kind of doesn't really matter, historically speaking. You had the Rice approach, what is it? Rest, ice, compression, and elevation.
Yeah.
So that's the thing that they taught me when I was coming through athletic training school. I think that thing is still floating around out there. I think for the most part, people have realized that that's probably not the best thing to do. If you haven't heard that, I'm going to say that the old school Rice is probably not the best thing to do. I don't think it's going to kill you by any standard, but we do want to get some movement in it. That's the big thing. Ice is fine to do that if you want to, but we want to get some movement. That's really the negative about the Rice approach, is that we end up not moving. And then, like we learned with the healing process the other day, we need that movement to get that lymphatic system working to really pull that inflammation out, because ice doesn't really do anything for inflammation, really.
Yeah, something because they did mention Rice, but I guess there's like this new acronym for Rice, which I do like as a CSCS, just because I do think there is a lot of underloading in like normal clinics. But something they talked about is moving away from Rice and going into something called police. So police is protection, optimal loading. So it includes loading and then ice and elevation. Would you say that's pretty standard for how you use ice for the most part?
Yeah. Actually, that's the first time I've ever heard a police. So that's actually, I'm going to steal that if you don't mind.
There you go.
So no, that's absolutely right. That's really, really good. Yep. So we want that optimal loading is kind of a very key phrase. And we kind of talked about that a little bit. And then I'm sure we'll get into it a lot more when we get into like therapeutic exercises and things like that. And sometimes that is kind of difficult to understand. What is optimal loading? What's overloading? What's underloading? All that jazz. And so that's a whole conversation in itself. But I think you're absolutely right. So traditionally speaking, again, we're going to use you as a great example. An acute ankle sprain, putting ice on it. Yeah, I think that's fine to do. If you don't put ice on it, is it going to be the end of the world? Probably not. The more important thing probably from acute standpoint would be the compression side of things. And so that's where you talked about, y'all did ACE wraps. And so for like an acute ankle sprain, which happens, I had a kid just the other day, a football player, he comes in to the office and he rolled his ankle. It's like Wednesday, they got a football game on Friday. He's like, man, what, things swelled up like a little goose egg on there. And so are we going to put ice on it? Honestly, I didn't put ice on it.
Yeah.
But what I did use our Normatec recovery boots. It's a sequential compression to get some of that swelling out of there, get that foot elevated above the level of his heart, and then we got on a little blood flow restriction therapy stuff. Again, that's more therapeutic exercises. But I actually kind of was using it like a modality because we do get a lot of anti-inflammatory effects with the BFR. So if you want to kind of think of it from that perspective, maybe you can think of it like a modality. I don't know, maybe, but got him on the bike and got him moving. And like you're talking about that optimal loading. So ice, especially that isolated, hey, I'm just going to wrap your ankle. I mean, yeah, good. If they like it, it makes them feel better. It makes them feel like they can do more stuff. Then yeah, I'm all about it. Again, is it really going to change the overall healing process? Probably not. Kind of same thing with heat. I'm probably not going to put heat on an acute injury where we have a lot of blood kind of already perfusing into the area. It might make that swelling a little bit worse. But at the same time, I mean, if it kind of makes them move more to where I can get into more of that optimal loading aspect of police, that may not be the end of the world.
Yeah, that's something we talked about too, like, and that I've heard as working as a CSCS, like, the modality that may be best may be just what your patient feels best doing. So if your patient hates ice, you don't have to ice them. If they really feel good after ice, just getting the feedback from them to know what they like and what they feel better. And then we also dived into like the order of modalities. So kind of the therapist gets to decide. So if you want to use ice to try to bring down the pain response that's happening, if you could decrease the pain response, then maybe you're able to push the exercises more or get more range of motion, not specifically from the ice, but through assistance from the ice, and using that to try to numb the pain response so that you can get more out of your exercise. With the compression too, because I'd never seen an ACE wrap. I think I was spoiled with the Normatec. So we mainly talked about two because we did do the compression boots as well, but having ACE wraps is something that obviously the patient's not going to be with me 24/7. So if I want to use compression boots when we have access to them in the clinic, but then want to send them home and keep the ACE wrap on it to try to help with the swelling when they're not with me, using that as an assistance device too when they're at home and by themselves before they come to me for the next session.
Yeah, absolutely right. It is. We got all the bells and whistles in the clinic, and then it's like we got to remember, man, we got to send this person home, and it is really, you got to be careful. Don't get stuck in that one step forward, two steps back type of mentality that it's like, man, we can't make any progress unless they're here with me at the clinic. And that's a tough spot to be. So ACE wraps, especially when it comes to edema control, any kind of swelling control, ACE wraps are a tried and true thing. They've been around forever, and man, they just work. You know, we use them, especially our post-op, like our post-op total knee replacements are probably the best example of utilizing an ACE wrap today. If you get into some clinics where there's some like lymphedema and that kind of rehab stuff that you don't see every day, but there are places to do that, you're going to utilize ACE wraps. They have some like stockings and stockinette type things nowadays that make that easier. But again, if we're looking, great example, acute total knee replacement, we're talking about that first week. They're going to come in, we're going to use our Normatec boots or whatever boot we have, and it's going to push that edema out. But like you said, I got to make sure I have some kind of compression on there when they go home. Otherwise, that thing's just going to fill back up. And so we use the ACE wraps for that. Pretty standard. The biggest thing you got to watch out with the ACE wrap, though, is number one, there can't be like space in between. You know, like if you wrap it and there's like a little space in there, boy, that thing's going to fill up. It's going to get nasty looking. And then we always try to go pretty far below. Going below the area is more important than being above the area. For obvious reasons, we're trying to push everything back centrally so our body can process it. And so with a total knee replacement, you know, you either need to use 2 ACE wraps or get like the really, really long ones and start at that foot and work your way all the way up there. And, you know, even if you're just in like right above the patella, like that's fine. Like we don't need to go mid thigh. You know, sometimes you think I got to get that ACE wrap kind of high. You really don't. It's more important to get that compression below so we can work everything centrally and get that junk out of there.
Yeah, so would you say most of the ACE, when you do see ACE wraps, is most of the time it's like post-surgery with more of like a older population? Is there ever an instance where you would necessarily use it with an athlete or not really?
It really depends on how acute you see them. Like I said, I will see an acute patient from time to time. And usually it's just because the way I work, I do have relationships with these teams. You know, we're in a performance facility, so it's a little bit different. Sometimes they just text me and they come in, so it's not like official physical therapy stuff. So we kind of run our system more like an athletic training room. You know, we will get some acute stuff like that. Typically, when you're in just a regular orthopedic clinic, you know, they either got to go to the doctor first to get the order, but even if you're seeing them direct access, they still got to get on your schedule and stuff. So a lot of times you just don't see an athlete super acute. Most of the schools have athletic trainers with them now, so that's kind of their department. You know, the athletic trainers are handling that acute stuff. If we got to get into like the rehab, heavy rehab stuff, that's where physical therapists really, really come in. So it's like, yeah, we can do that, but let them, that's their wheelhouse, do the acute stuff. So that's where all that ice, getting everything calmed down, the compression and all that stuff. For us physical therapists, typically it's going to be a post-op patient. Yeah. Like you're saying, the total knee is the easiest one. You know, if you're in an orthopedic clinic, it's kind of like low back pain and total knee replacements are probably the top 2 things you're going to see. So you're going to see a lot of that. And of course, when they're swollen like that immediately after a total knee, you know, we're going back to police, optimal loading. They don't want to load at all. You know, they look at it and they just think, oh, that thing's huge. It's not ready to load. I'm super fearful of everything. It hurts because everything's really puffy and tight. So it's, man, we got to get that stuff out of there. So, you know, acute total knee, if we're using that as our example for compression in particular, and that's a lot of compression on the front end. If they come into the clinic, I have an hour-long session with them. I'm starting my session off with that. I'm starting with compression. I'm also going to start with E-Stim. We can talk about E-Stim a little bit right here too, because you can use those modalities at the same time. That's one of the things I love about a Normatec recovery boot is it's working hands off. I don't have to do like a massage. There's like a lymphatic drainage massage. No, we're not doing all that. We're just going to let that thing work in a sequential way. And I can throw some electrical stimulation on there for some pain control. I mean, that's really, you kind of look at E-Stim in two different ways. Is it going to be pain control on one side, or is it going to be muscle activation on the other side? Acutely, we think of it much more from a pain control side. So that'd be like in the clinic, we use IFC, interferential current would be what we would typically use in the clinic. But you have like a TENS unit that the patient can get. I mean, you can get those on Amazon now. I mean, they're so cheap, like $30 on Amazon, and they can have a TENS unit that they can use at home. I mean, you could teach them how to use that. Acute total knee replacement in particular, top two modalities that I'm using for them, it's not going to be ice. Honestly, I can't remember the last time I put ice on a total knee replacement, but we're starting a session with IFC and compression. Then we're going to do some optimal loading. I love the police thing. That's just great. Like I'm totally stealing that. It's fantastic. So we're going to do some optimal loading, and then we're going to finish probably with another round of IFC and compression.
Yeah, because even what we talked about E-Stim loosely, and that's like the ice massage and the ice pack and heat packs and all that stuff. Most people are pretty familiar with if you went and shadowed in a physical therapy clinic. But with the E-Stim, really all we talked about was, just because we haven't got to that section yet, is that it's going to decrease pain and then also help with tissue healing. To my knowledge, E-Stim is deeper than like a heat pack, and it just sends heat waves to the tissue. So how do you kind of differentiate like when you want to use an E-Stim versus a heat?
I think you're thinking ultrasound. You're saying E-Stim, but I think you're thinking ultrasound. Yeah,
See,
cool.
I don't know.
No, you're absolutely right. Yeah, so E-Stim is like, again, two different things. It's electrical stimulation. We're using it for pain control, and so that's going to go, but kind of based off the gate control theory of pain. And then we can talk about it here in another example down the road of how we're going to utilize that from a functional stimulation, muscle stimulation standpoint. But yeah, if you're looking at kind of our thermal modalities, ice, moist heat pack, that kind of stuff, those are the things we all know. The next level up probably would be ultrasound. And you're right. I mean, the biggest difference is ultrasound is sound waves. So it's completely different in that aspect. But one of the main goals is, yes, we're trying to create more heat at a deeper level. So that thermal ice pack, that thermal heat pack, it has to work from the outside in. It takes a long time to get through that. The level of penetration, if you look through all the research, it's not very far, So when we're dealing with the ice pack or a heat pack, you're really addressing the superficial tissue. So if it's like, hey, we're going to put this thing on there and we're going to use that to help control inflammation, it's going to be hard for me to drink that Kool-Aid knowing that it only penetrates like a millimeter down, like it really barely gets through the skin. But to your point, what you said earlier about it, if we're looking for it to calm the sensory nerves down, knock that pain down a little bit so that we can do some optimal loading, yes, 100%. I think that is a more appropriate way of thinking about it. The ultrasound is going to give us sound waves, so it actually penetrates and goes through that tissue. And so we're actually getting nice and deep and heating that tissue from the inside out. That's kind of the way I explain this to the patients. So like, hey, I'll tell them, hey, a heat pack heats it from the outside in, the ultrasound heats it from the inside out. And they're like, oh yeah, that sounds great. And so we're going to get a little bit better penetration. The other cool thing, like you're saying, is it is going to help stimulate some of the healing factors there, right? So all that inflammation and all that kind of yucky stuff that's in there from the injury, it's going to help flush that stuff out. That sound waves, there's physical movement, when sound waves hit it, it's going to flush that yucky stuff out of there, which makes way for a good new nutrients to come in there and help promote a better healing environment.
Yeah.
Now, again, there's drama a little bit with that, does the ultrasound really do what the ultrasound says it does? Again, for every research article that says it does it, there's probably one that says it doesn't. Clinically, patients do get better when you do it. It may be a psychological thing. It feels good. Have you ever had an ultrasound?
I have not. No ultrasound.
Oh, man.
a TENS unit, but not like an actual like fancy one. But no ultrasound, so I have no idea what it feels like.
Well, ultrasound feels good. It really does. They put that cold gel on you and it's like, oh, it's cold. That kind of shocks your system a little bit. But then as they're using the wand, it's got this little crystal in there that vibrates and that creates the sound waves. And it will start to heat up a little bit. And of course, they're rubbing it on that area. So you're getting that little sensory stimulation of those superficial sensory nerves. And it feels good. It's almost like somebody scratching your back or something. It's real light. It's real soft. It just feels good. And so if you get done with that, I mean, the patient probably is like, man, that felt great. I would say probably greater than 90% of my patients that's what they said after it. They're not like, oh, the tissue's really warm and all that stuff. They're not saying that. They're just like, man, that felt really good. And
Yeah,
so now,
is that something you would tend to use, like as far as order, would you use ultrasound before your exercise intervention for the most part?
yes, usually I would. Sometimes it depends on just the flow of your day, right? So we got to put practical talk in there that if I'm seeing, 12, 13, 14 patients in a day, I may be running and gunning. It's like, I just don't have time to get to it until the end. So it's not the end of the world if your order gets out of whack, so if you end with it, that's okay. If you can start with it, maybe that would be a little bit better because it does kind of prep the system. Yes, we're increasing blood flow to the area. We're desensitizing some of those sensory nerves. Psychologically, the patient is kind of settling into, hey, it's treatment time. They feel like they got a treatment. So they're just like, hey, I feel like I got pampered a little bit. So they it gives you a chance to talk to them. Then you could, what's your history? Those 3 discovery-based questions that we talked about. And you really just kind of gives you a chance to set the mood a little bit, as weird as that might sound. And then it's like, all right, cool. We got you warmed up now. Now let's see now that tissue's prepped and ready to work, now let's get into work. And so sometimes it does kind of psychologically get them to shift into more of that, hey, it's time to optimally load you now. And so ideally, probably at the beginning, but again, if you can't get to it until the end, I think you're probably fine there too.
Yeah, even with the ultrasound, is it because when I think deep now, well, let's say now that I have my thoughts aligned, I think I stood there for a second that I'm the student and not the experienced clinician. So like with ultrasound, for some reason, when I think deep, I think like tendons and ligaments. So would you say ultrasound is more to target tendons and ligaments versus like something superficial like muscle? Or
the answer to that question is probably going to be the answer to most of them. It depends. It depends on what you're trying to accomplish. And that's maybe one of the toughest things for a young clinician is you come out thinking that it has to be like this. You're kind of looking for that recipe, and the recipe doesn't really exist because it just depends on what you're trying to accomplish that day with that patient and where you are within the overarching period of the rehab process. Especially if you have some of these post-op patients that may be a little bit longer in the rehab plan. I might be using ultrasound more from a tissue healing perspective on the front end and more for, hey, let me just heat the tissue up on the back end. So sometimes while you're doing things shifts just a little bit, even though you're doing the same thing.
Yeah.
But to answer your question would be, you can do it on whatever. You're not going to do it on bone like that. The bone just absorbs the sound waves and then it ends up hurting. Like that's when y'all do it in the lab, they'll probably make you do that. They made us do it, like hold it on that bone until it hurts, and you get that vibration stacks up in that bone, and that bone is just absorbing it. And brother, it feels like an elephant's crushing your bone. It doesn't feel good. So obviously anything hard like that, obviously anything metal. So like a total knee replacement, we're not going to go and like, hey, let's ultrasound the patellar tendon. It's like, no, there's a hardware under there. I don't want to do that. But if you have a muscle strain, we see it a lot in athletics with especially like soccer players because they take knees to the quads a lot.
Yeah.
So you get like a hip pointer or something like that in football where it's just like basically it's a deep muscle contusion where I need to get that yucky blood flushed out of there. Because obviously if that blood just sits in that muscle, then bad things happen down the road. And so we'll use that to maybe flush that out. Obviously a tendonitis, we think of that, we're going to flush the inflammation out of that tendonitis, make it a little bit more supple where it will actually accept a little bit of a stretch and a little bit of load. We can do that. The ligaments, it just kind of depends because ligaments are usually pretty deep. you know, so it's like the superficial ones. The lateral ankle sprain is, again, probably the easiest example of that. Those ligaments are very superficial. You know, it's probably the number one injury. Definitely the number one injury we see in sports is just a traditional lateral ankle sprain. I mean, so that's probably where I do the most. A lateral ankle sprain, maybe Achilles tendonitis. We have a lot of basketball players that we work with. So like Achilles tendonitis, patellar tendonitis, those are going to be real big. Bicep tendonitis here in the shoulder, you know. So again, flushing out some of that yucky stuff, getting the new healing juices flowing in there, makes them feel good, preps them for a little bit of loading. So that's usually how we utilize ultrasound.
Gotcha. So yeah, I kind of want to touch back on E-Stim too, because we obviously haven't done E-Stim yet, but one of the big things we talked about on E-Stim that's different than ultrasound and thermal agents or acoustic is that we like to use it to make sure the nerve can still talk to the muscle. So in what instances would you like use the E-Stim where you're really trying to have the nerve talk back to the muscle and get the nervous system firing again?
So let's use an ACL as an example. That might be because we're going to use E-Stim in both ways with an ACL patient, right? So acutely, like we talked about already, the E-Stim is going to be a pain modulator for us, right? It's going to help calm all those sensory nerves. We get a low level of vibration. So low intensity level. It should feel like ants crawling on you. That's what I usually tell people. They're like, ooh, that kind of feels good. Something, yeah, it tickles. Yeah, it's like, yes, it feels good, right? So we want to take away that noxious stimulus that they're getting from the pain receptors, cover it up with a good stimulus. And so that's what we see. ACL, the first probably really just 2 weeks, you're probably going to be pretty hard on that kind of stuff. They'll probably get it every single time they come in because we want to really control that pain. If we start loading them, they may be a little bit sore, a little bit sensitive to some of that optimal loading that we talked about. So not a bad idea to kind of finish up just so I want you to leave feeling good. That's kind of what I always say. It's like you come in, maybe not feeling the best. Goal number one is you should feel better when you leave than when you came in. If your patients are just getting crushed, especially like your acute ACLs, your acute total knees, where you're like just crushing them and they're leaving limping. That's kind of one of the reasons I don't use ice a ton at the end because it makes them more stiff. And usually they're like, yeah, I didn't feel super great. I was really stiff and achy when I left. That ice kind of stiffens them up. But anyway, so we'll use that from, you know, those acute stages, that first month of an ACL, pain control. All right. So there's one E-Stim, and you got different types of current. That's the interferential, pre-mod, Russian stimulation. There's a whole laundry list of stuff. To be honest with you, I would have to look up what all the differences are in the wavelengths and things like that of it. Luckily, the machines, you just hit the button and they're all preset. So thank goodness for that. If I want Russian, I hit the button that says Russian stimulation. And so we have the sensory stimulation side. That's for pain control. But then as the rehab process goes on, to what you're talking about is, hey, we need that brain muscle connection. We need to reform that, especially with an ACL. They are notorious for having what we call arthrogenic inhibition, which just means that there's an inhibited muscle, really the vastus medialis, that gets inhibited because of what happened within the joint. Arthro, that's the joint. Genic, the beginning, and inhibition, arthrogenic inhibition. And so they're really, really bad about having that muscle get inhibited. So that basically is just saying the brain is not controlling that muscle very well. So you're like, hey, I need you to straighten your knee. Well, that VMO should be activated really high to cause that knee extension. Well, unfortunately, that's not happening. Kind of another unfortunate thing is there's a bunch of other muscles in the quad there that they're just going to take over. And next thing you know, you're using all those other muscles, but like the VMO is just not getting utilized the way it needs to be. And it is just a key muscle for anterior knee health. So anybody that's coming in with anterior knee pain, total knee replacement, ACL, all the stuff, the VMO, we need that guy working. And so we're getting to the point where we're starting to load a little bit. Some of muscle activation simply comes from a load. There is a threshold. This from being a CSCS, but maybe those that are not super familiar with being around the weight room per se, is like there is a threshold that we have to get to get that muscle to activate. And that's one of the challenges in physical therapy is we're so kind of kit gloves with everybody sometimes that we never actually get to a heavy enough load to to get the muscles to recruit all those motor units that need to be recruited. And well, if they don't feel the need to be activated, then the body's not going to activate them. So I can't form that connection. Well, the cool thing about E-Stim is it forces the issue. So even with the lighter stuff, so now we're back in that our police. What would that be called? Not an analogy. What's that? When it has letters that mean something. Acronym. Thank you. All right. So our police acronym, the optimal loading. All right. We're starting to load them, but we can't really load heavy, especially if it's a patellar tendon graft or something like that. Like I don't want to load that extensor mechanism if we're still hot and irritated from the graft site. So we'll bring the E-Stim in there. We got to turn the intensity up. The biggest difference really is the intensity. There's a waveform difference, and you'll learn that in school. And like I said, I would have to look up all those parameters. But the bottom line is we go from hey, this should feel like ants crawling on you. Oh, that feels great. To, hey, this is not going to be comfortable at all. It's going to feel kind of like that muscle wants to cramp. So those are the two biggest differences. And so now we're in this muscle stimulation. We're going to crank that intensity up till the electricity makes the muscle contract. So the patient really has no choice. That muscle is going to work. And then we have them work with it. And that helps reform that brain muscle connection.
Yeah, I think something we've talked about before, I'm going to sound really smart here for a second using my bad language. But something that kind of confused me at first is like, why would I use an E-Stim over like an exercise? Because exercise is like the best. But the way you explained it was that the body's always going to find a movement pattern to go to get the task done. So if I were to just throw someone on a leg extension machine where I'm trying to go for VMO activation, if the VMO is already not firing, the person's not going to get the leg extension up by using the VMO anyways. So I like to associate E-Stim with more of like an isolated approach, and then try to use like therapeutic exercise to then reteach the muscle pattern after we get the muscle connected back to the neuron. Would you say I did pretty good on my Brad explanation?
Yeah, man, that was fantastic. That was very good. I mean, you're absolutely right. That's the thing. Our bodies are really good at getting the job done, and so especially, we were talking about ACL. So that's one thing. They're young and all that stuff. But if we put it in the context of a total knee replacement, sometimes we have to use the electrical stim with them from that way. It's a little bit tougher because again, the stimulant is not super comfortable. And those older patients, a lot of times we're like, oh, I just want them to feel good. So we never do anything where it is uncomfortable for them, but they need to be pushed. And we need that overload principle with them as well. And so I'll use that functional stimulation, or that motor control stimulation with them because we're having to retrain everything. They've been limping around for probably years before having this total knee replacement. So yeah, they got compensation all over the place. Same thing, especially female athletes are tough. That female athletes like to play kind of high. If you ever watch them, they don't bend their knees very well when they're playing. Girls, no offense to any girl watching this, but you just don't get down into the quads very well. So it's really, really easy for them to find some other way to walk around and some other way to do stuff without really pushing that knee forward over the toes and getting that proper knee flexion that we have to get the VMO to kick on. And so a lot of it's positioning with our exercises and things like that. But like you're saying, man, we're really using that to retrain the whole system and carve out this new neural pathway.
Yeah. So I think, to my understanding, we touched on all the modalities. Would you agree? I'm not missing any?
No, I think I have a list here. Let me look at my board. So we did ice, heat, E-Stim, ultrasound, and compression. So those are the ones that you've kind of gone over. So yeah, I think we hit them all.
So we did the major modalities that most people are aware of or at least have heard about. Is there any modalities not on the list that you like to use?
There are. So the ones we talked about, like you said, are the major ones. Those are the ones we're going to use all the time. A few, we'll go over just two. I have two on my list over here that I think would be worth talking about that I've been playing with a lot over the past couple of years. The first one will be a vibration plate. And so vibration plates came around a long, long time ago. I mean, years and years ago. They were really big in professional soccer. The NBA tried to mess with them a little bit because they were using it more for like a muscle activation, kind of a systemic primer. But then they were like, man, it's hard lugging all these vibration plates around. You know, they're like traveling all over the country and stuff. They're like, I don't want to lug this around. But we can use it in the clinic, and they don't have to be those big fancy ones. They have the, super big expensive ones. Again, the one I use, I get it off of Amazon. It's like $50, And so a vibration plate, and we can use that in a bunch of different ways. This is one of the reasons I like it. It depends on where we are within our stage of rehab. So if we're really very acute, say again, let's talk about an acute knee that's kind of puffy, got a lot of swelling in there. We can't really load it at all. But again, I'm trying to really have an impact on those sensory nerves, get that sensory system to calm down a little bit, to get that entire system, kind of the vagus tone that we've maybe touched about in the past, where, post-injury, post-surgery, their system as a whole is kind of default sympathetic, scared, panicky mode. If we can shift that over into the parasympathetic state, that's huge for our rehab. Like, we don't generally heal in the sympathetic. That's the fight or flight. And so we need to shift gears over into the parasympathetic state to promote healing, get growth hormone, all that stuff. And so from an acute standpoint, like, how do we do that? And I'll be honest with you, one of the easiest ways that I found is this vibration plate. And there's a bunch of different ways you can do it. You can have them stand on it, lay on it, do different things like that. But in short, all it's doing is shaking you. It's just a little vibration, right? And so I'll team that up a lot of times with compression. So if my goal is to help lymphatic drainage, that vibration like that is going to help get that lymphatic system draining a little bit. So if you're trying to promote lymphatic drainage out of the legs, I'll get them on a table, elevate the feet above the level of the heart, Normatec boots on there. So we're getting compression. And then I'll put their legs with the Normatec boots on and everything on top of that vibration plate. And it has that little bit of vibration. And so that's going to really help promote some lymphatic drainage. We're going to get some of that sensory nerve stimulation. They're going to start relaxing because it shifts you, that vibration, that rhythm that it creates, shifts them into parasympathetic, and they just melt. It's pretty funny to watch. You're just like, whoa, that was like, I'm ready for a nap. So that's one that I use, and use it acutely. If we go more chronically, so again, if we're looking at our ACL and we're like, hey, we're ramping up, we're ready to load you a little bit, then we'll stand on it and we'll use them like that. Because again, that vibration is going to get those muscles to fire automatically, right? Because it's just the perturbation that happens to it is almost like our postural sway. It's happening so fast that there's no way that I can consciously say, hey, I want to activate this muscle or whatever. That muscle is going to respond to the stimulus of those mechanoreceptors, and it's going to start kicking on automatically. And that's what we really need to do before we're prepping the system and going into the proper strengthening stuff. So vibration plate, I just love it. I have one at my house. I use it on myself. I use it on my kids. Even when we get colds, like we'll get head colds, and we'll stand on it or sit on it, and it really helps drain the sinuses. It's just great.
Yeah, because even thinking too, anytime I've gotten injured, at least I definitely am in flight or fight mode. Like, I'm not just chillaxing, and it definitely like freaks you out. So most of the times too, as physical therapists, someone's coming to see you because they are in pain. So something that we even talked about too, not specifically with vibration, but just with modalities in general, just giving the person a different stimulus that isn't pain to try to take their mind off of pain, just because there is a big mental aspect of pain. So do you think that that's something that vibration could be useful for, especially with it being such like a unique feeling that maybe people haven't had?
Yes, you're absolutely right. So all those modalities, yes, all those can help with getting you out of that pain cycle. But especially if you're looking at your chronic low back. So when we talk about pain, the first patient that you're thinking of is going to be your chronic low back patient, because they do get stuck in this pain cycle, and it starts to overtake their life. And I mean, I got a couple of them right now, and one that she literally, couldn't go to the bathroom by herself. Like, that's how bad her low back pain is, or was. We finally got her out of that. Like, she was able to hex bar deadlift 95 pounds, 4 days ago as of right now. So to go from, I can't sit down on the toilet by myself, to being able to hex bar deadlift 95 pounds, that's huge for that person. But one of the places we started was with the vibration plate. She has one. I told her where to get it and everything. She has one at home. And that was, like you're saying, we got to break that cycle. We got to get you out of pain mode to where you're just obsessed with it. You get that fear. What's the big word for it? Kinesiophobia. or whatever it's called. Don't ask me to spell it, but kinesiophobia, where just because of the pain, you have all that fear. If I have all that fear, I'm not moving. That goes back to our police. How do I optimally load somebody if they won't move at all? Like, it doesn't work.
That's why I'm really interested in pain. So we're starting to dive into the pain tracks and stuff. So hopefully we could get into that sometime, which would be fun. But yeah, I think just to kind of wrap it up, modalities are just a great tool to assist your manual therapy and exercise interventions, and knowing how to use them, and then also taking into account like the mental aspect of doing whatever makes the patient feel better could go a really long way than being like so specific of like ice is used in this exact scenario for this exact outcome, but then your patient may just like ice and then just mentally feel better after ice. So I think that's a big takeaway off the modalities.
Yeah, you're absolutely right. Getting out of the rigidity of it and just know it's a little bit more free flowing. I do have one more that I want to talk about. So vibration, I love that one. The other one would be red light therapy. I think I maybe have shown you that before in the clinic. And again, it's a useful tool because you can get them off Amazon. They're not really regulated by like the medicine world, so they're not super duper expensive. They've been around for a long time, and it does wonders for anti-inflammatory effects. It's great for tissue healing. It's kind of marketed as like a beauty product because it's going to help promote some collagen growth. It's going to improve the mitochondrial function of the system and all this stuff. And one of the areas that we use that acutely would be with wound care. So if you're immediately post-op and you got an incision on there, I need that incision to heal. I utilize red light. It does get a little bit of heat with it. And so we are getting some of that heat effects, but with a red light, which is basically just near infrared. It's kind of like going out into the sun and tanning. I know you like to get out and do a little fair share of tanning.
It doesn't look like it right now, but I've been slacking ever since school started. I think like I'm reflecting light now. Like if I were outside with my shirt off, it would just be like a big bright white light.
Well, it happens. At least you got an excuse.
Yeah.
So those are kind of two new ones that maybe you don't see on the regular, but when you get some time, look into them. Or whatever. But yeah, vibration and red light, those are two that you don't commonly see. But yeah, I think you hit the nail on the head that these modalities are not just part of the recipe, that you sprinkle them in where you see fit and kind of understand, okay, what is the goal that I'm trying to accomplish today? Can that goal be enhanced with a modality? And if it can, what modality? And then what way I'm going to utilize that modality? And if it's not, then don't waste your time with it. Sometimes we get caught up where I have to do this. No, we're going to prioritize our interaction with the patient. That optimal loading that you're talking about, that's how they're going to get better in the long term. All these modalities, they're just there to help us accomplish our goals.
Cool. So next episode, we'll see you guys hopefully. Even if one person is watching and benefiting from it, whether it's like a student or a physical therapist, just trying to touch up their expertise, hopefully someone did benefit. We are going to post some Instagram reels of some hands-on stuff. So Classroom to Clinic on Instagram if you want to see that. And then we'll be back for the next episode, and who knows what we'll talk about.